Hi there. This is Jess. We go by Dr. Jess sometimes from Premier Physical Therapy. And I'm here today to talk to you all about shoulder pain. So, shoulder pain can be caused by a lot of different things. I'm not going to go over every possible diagnosis that could happen with shoulder pain, but I'm going to go through some of the common things that can happen that create shoulder pain. And then from there, we're going to discuss a couple things that can be helpful. And then we'll leave it for questions that are going to be at the end. Okay. A little bit about us. So we're Premier Physical Therapy. We are local to the Jacksonville area. We've got a clinic on Beach Boulevard, and we've got a clinic out in Ponte Vedra, and we are PT owned. And we have a couple of different subspecialties, which is great. So we've got orthopedics. We can treat anything from head to toe. We can treat head and facial pain, pain with the jaw, lymphedema, and after cancer treatment as well. Then we've got some running and golf programs and any sort of like athletic recovery that you might be looking for. So the shoulder itself, it is an amazing joint. It allows us to do an amazing amount of mobility and activities, as we can see with pictures and people that can reach pretty far behind their back, but also can become stiff and then have some problems that are associated with that. Now, when we get into the anatomy of the shoulder, so I always like to educate patients on why things can happen. And in order to understand that, we have to go down to the anatomy and really understand what are some of our key players. So as you can see, we've got a couple bones that are important. Okay, we've got the scapula, which is your shoulder blade, and then we have the humerus. So that's what creates the ball and socket. Okay, so the socket being the shoulder blade, and then the humerus, the arm bone, at the end of it is the ball. And so that is our true joint of what we call the shoulder joint. We have a couple of other joints that are important, okay? Where that collarbone or clavicle comes across, okay, that also creates another joint, which can become problematic because of different reasons, but it does play a role in mobility for normal shoulder motion. The other bony anatomy that's important is your thoracic spine. So that's the mid-back, okay? Because when you become kyphotic or stiff, it actually prevents the mobility of the scapula. And we'll talk a little bit more about that in a minute, but that can really start to create some dysfunctional movement patterns. So when we think of shoulder, we're not just thinking of just the joint. We're thinking of a lot of the anatomy around that joint, because understanding that is how we truly understand what the current dysfunction might be and what might be creating the pain. So muscles. Now, we've all heard of rotator cuff muscles. What are they? Those are the muscles that actually help to control the position of that humeral head, okay? So there's a series of muscles. Most of them are on the back of the shoulder blade, and then there's one that sits right on the front of the shoulder blade. And they really help to stabilize the humeral head within the joint. Then we get out to the more global muscles, okay? So the biceps and the triceps and the pecs and the traps. And those are the muscles that actually help to move the long bone of the arm itself. So we've got rotator cuff that help to stabilize the humeral head within the joint. They also help with other motion, but they're really big on stability here. And then we've got global muscles that help to create motion of the long bone, okay? Or the global muscles that actually help to get the shoulder blade to move in the directions that we want the shoulder blade to move. So the sequencing and timing of how all these muscles work together are very important for normal mobility. So other thing that we always want to think about are nerves, right? So we've got to have normal neural innervation into the muscles in order for those muscles to contract like they're supposed to, okay? And then if we have maybe a nerve that's mad or pinched or something's going on, it could be referring pain into the area of the shoulder. So the shoulder pain may not even be the shoulder itself. It might be coming from the neck. Who knew? Okay. So all different things that we're going to talk about, but really getting a baseline understanding of the shoulder anatomy itself helps to the rest of our conversation that's about to happen. Okay. Now, proper movement. So what we need to know about this is that everybody thinks like, oh, if I just stretch or if I'm just super strong, then I'm going to be all better. It's never that simple, okay? We need both mobility and stability in order for us to have normal movement, okay? So we need normal mobility of the joint, okay, of the glenohumeral joint, okay? We need normal mobility of the thoracic spine. We already talked about that. And we need normal mobility of the shoulder blade moving on the rib cage itself, okay? So when we talk about joint mobility, it's not just the shoulder joint. We also have to consider the shoulder blade and the mid back as well, okay? Now, ligaments, right? So we need ligamentous mobility. Now, we don't want too much, so we don't want it to be unstable, but we don't too little where you actually feel like you can't move, okay? And muscle length. So, for example, if your pecs are really short and tight, okay, that's going to roll the whole shoulder blade forward. So when that happens and that shoulder blade rolls forward, I'm actually decreasing the space that I need inside that joint. So then that's not good because I'm going to start pinching and rubbing on stuff, and I'm going to increase my likelihood for impingement or rotator cuff tears potentially, okay? So that's all the mobility part. Now we think of stability. So when I first discussed the muscles of the rotator cuff and the muscles of that move the long bone, and then the muscles that move the shoulder blade, okay? So when we talk about muscle control, what we mean is that we need the muscles to be able to not only stabilize the humeral head, but we also need the muscles to be able to coordinate and time appropriately the movement of the shoulder blade and the movement of the long bone of the arm, okay? Because when we don't have this sequencing and timing that happens, then what happens is if, say, that shoulder blade just isn't doing what it's supposed to and it's not dropping and rotating, okay, to allow the long bone to come up, okay? Let's say your body decides, I'm going to elevate, okay? So that's what we call it a shoulder hike. So if it elevates and then I start to move, oh no, now I'm starting to get this bony approximation. I start pinching. Well, we have a bursa that sits right there, and we have rotator cuff tendons that sit right there, okay? So we can start to wear down the tendons or push on that bursa, and we create all sorts of pain. So the control of the muscles is hugely important, okay? So when we say muscles of the surrounding regions, what we mean is not only just the neck musculature, the mid-back musculature, the muscles of the arm itself, and of the rotator cuff. So there's a lot that goes into how this joint moves in a normal way. So that's normal, okay? Now we talk about what can go wrong. Because if you're watching this, you probably have something going on, which is why you're actually interested in hearing me talk about shoulder dysfunction, okay? Now, the main things that can happen, okay, are that we can get impingement, we can get muscular sprains or tears. Most commonly are the rotator cuff or biceps. And then we can also have impairments in the neck or mid-back, okay? So all of that are just like the common diagnoses. There's a myriad of other diagnoses as well. I just don't want to bore you by talking for 2 hours about shoulder dysfunction, okay? But if you come into the clinic, obviously we would be screening you for the entire myriad that could be going on. Okay, so shoulder impingement. What is that? That sounds awful. Well, it really is not fun. But what you need to know is that in most cases, it's non-surgical, okay? And you have an excellent response to physical therapy. When we look at the shoulder impingement syndrome, okay? So like I was telling you before, as you can see in this picture, it might be a little bit small, but what we're always looking for is there space between the humeral head, okay? And then that the top part of that bony anatomy, okay, which is made up at where the shoulder blade and we've got the clavicle that come across. So if you don't have adequate space in there, it might be a postural reason, it might be an arthritic reason, it might be just a muscular control or habitual reason, right? I habitually sit like this, just going to roll me forward. But I might also have a very shortened pec, and I actually cannot come out of that. I might have compression fractures in my thoracic spine that have put me into this forward rounded posture. Many things can cause why this eventually turns into pain. So we always have to look back at, okay, what are all causative factors for what's going on to create the impingement? And that's our treatment plan, okay? We can't just say we're going to like just take the pressure off the bursa and take the pressure off the tendon, and boom, you're going to be fine. We got to look at you as for this whole body approach and make sure that your neck is moving appropriately, your mid-back is moving appropriately. We're trying to stretch out those pecs and get that stability that we're looking for so you can maintain the upright posture, which then gives you that joint space that we need. Otherwise, you're just going to keep pinching on it. So I need you to move without pinching on the bursa or these tendons that are coming across. So with that shoulder impingement, typically it creates pain. You'll have pain that kind of radiates down the shoulder a little bit. It's worse with reaching across your body or overhead, commonly will cause pain. So all very treatable in the clinic. Now, other things that could happen, okay, are tears. And we've all heard of rotator cuff tears. Oh my gosh. I had this MRI and I've got this tear in my rotator cuff and, oh, this is the worst day of my life. Okay, now, yes, that's not fun. And yes, it can create some pain. But I think one thing that we really do need to consider, okay, is that can rotator cuff tears occur and can the patient be asymptomatic, meaning that they don't have any pain at all? And the answer is yes. Okay, so 13% of individuals that are aged 50 to 59 have asymptomatic rotator cuff tears. And then as you get older, okay, that percentage increases. So individuals that are 80 years or older, 51% of them have some sort of tear in the rotator cuff tendon, okay? So when we go through a full evaluation, okay, what we're looking for are signs and symptoms of things that are treatable versus signs and symptoms of things that are red flags that would potentially be like, yeah, this is going to be a little bit too much for you to have most likely full recovery. Meaning like you actually can't really contract and move in the direction we want you to move, which that might indicate that you have a full tear and it's completely torn away from the bone, okay? Well, if the tendon is not attached at all, then obviously we can't do anything in conservative management. But if you have some of the tendon that's left and you've got decent function, you might have pain with range of motion, but we can still fire that muscle and we can get something out of it. Then we're going to try and treat that conservatively because we don't want to necessarily jump right the surgery right away if we don't necessarily need it. So don't always think of a tear as like direct surgical intervention. Sometimes yes, sometimes no. So that's what's important with getting an evaluation. Now, when we consider tears, okay, mild to moderate rotator cuff tears can heal with conservative management. So this is great, okay? Now, if it's a full thickness rotator cuff tear, okay, that's where it's more likely that you're going to require surgical intervention, which then you would just recover in therapy afterwards, okay? So really just getting when the MRI results come out, and they'll give you that in the report, they'll typically give a grade to the severity of the tear, okay? So that's a little bit more about rotator cuff tears. Now, other things that we want to consider, okay, are impairments in the neck and mid-back. So this is what I was kind of talking about before. So if we have somebody that's, we'll say, kyphotic, and they've got those compression fractures in the thoracic spine, and it pulls them into that forward posture, okay, that's going to create shoulder impingement because now everything is rolled forward, okay? So if I'm going to turn my body here, okay, and I go into my kyphotic posture, and I try and raise my arm, I literally cannot go past this, okay? Now, if I come out of that kyphotic posture, okay, and I raise my arm, I can go a lot further. So trying to really address what's going on. And you might not have compression fractures that lead to that kyphotic posture. You might just have a habitually poor kyphotic posture, okay? Maybe you sit at a desk all day. Maybe you're a student that's been home on quarantine and haven't been at school and sitting in your bed all the time doing all of your schoolwork, okay? Over time, if you put your pecs into a shortened position and you put your joints in your thoracic spine, okay, in this compressed position, you're going to get stiff through here, tight through here, and it's actually going to become hard to pull yourself out of that posture, okay? So all of those are things, obviously, that we would be treating, okay? Now, that's kind of what goes on in the mid-back. Typically, it's what we call that kyphotic posture that puts you into a forward head and neck position, okay? When we talk about the neck and what can go on, okay, you can have impingement of the nerve root in the neck that can refer pain into the arm. So, depending on which level of the neck that nerve is being pinched, depends on where in the arm the pain refers, okay? So, more or less, rule of thumb is lower in the neck where the pinching happens is the lower in the arm where the pain will travel. Okay, so usually around that C4, C5 nerve root area can refer pain into the shoulder or into the upper part of the arm, and so that's where we're going to be doing a screen for the neck to make sure that that's not what's causing the pain. Okay. Normally, if the neck is involved, you're going to be reporting things like numbness, tingling, burning, shooting, okay, versus like it pinches, it's a deep ache, it's sore, things like that. So you may have sensation loss, you might not. You might not even have pain in the neck. You might only have referral pain. So that's all things that are kind of important to think about, okay? All right, other things that can happen. There's all sorts of things. I'm saying this is not an exhaustive list, okay? So trigger points. So this is when we start to get some abnormal motor patterns in the muscles, okay? You can get trigger points or little knots that develop in the muscle itself. So when that happens, so think of our normal muscle tissue as striated and like so. When we get a trigger point, we get an area of that muscle, not the whole muscle, just a little part of it that actually goes into a contracted state, and it takes energy to come out of that contracted state. So when you've got a trigger point, it actually gets stuck like this, and it doesn't have the energy to release. Now, when you feel that muscle, and like, let's say it's your deltoid, for example, and you roll over that muscle, usually you'll feel like, oh, wow, it's kind of like a lump under my finger, a small lump, but a lump. And when I press it, it really hurts, and I feel pain elsewhere at the same time. So that's probably a trigger point. So this is what's important to really think about, that sometimes people have pain that's like really a decent amount of the arm or shoulder blade. And we're like, yeah, it's coming from your, we'll say, subscapularis. They're like, one muscle is causing all of this. And we're like, well, yes, because that's the referral pattern for the trigger point of that muscle. Okay. Now, when we look at a couple of the common muscles that can have trigger points, I've got some pictures here to show you. So the supraspinatus is one of the rotator cuff muscles. As you can see, the pain can travel into the upper part of the arm and then all the way down the arm. You have these hot spots where it might feel a little bit more focal, but you might not. Everybody's a little bit different. But one muscle can be causing pain that goes all the way down the arm. Crazy, right? I mean, it's kind of terrible. But the good news is that it feels like it might be coming from your neck because it's radiating down the arm. You're like, oh no, like I'm super scared. But then the neck screen was clear. Maybe your imaging was negative, and we go in and we start palpating the muscle, and you're like, oh my gosh, that reproduces my arm pain. We're like, yep, sure enough. Like we got to work on trying to decrease the load from that muscle so it stops working so hard, get rid of the trigger points, and then all of a sudden you start feeling better, okay? Now, when we look at the infraspinatus, that's another rotator cuff muscle. Also can cause pain. This time a little bit more, it wraps around into the front of the arm. So when we're screening you, you might be saying, it's my biceps, it's really hurting. But we're not finding anything wrong with your biceps. But then we go around to the back of your shoulder blade and we start pressing into that muscle, your infraspinatus, and all of a sudden it reproduces the pain on the front of your shoulder. You're like, what? So yes, that can happen. I promise, I've been there. I actually canceled tennis one day thinking that I flared up my biceps because my front of my arm was killing me. And then later that day, I was like, okay, Jess, think about this, right? Like, you did nothing to actually hurt your bicep. And I was able to pick up my work bag and I could do everything I wanted to. And using my biceps, then I used the ball and I found a little trigger point in my infraspinatus. And I was like, sure enough. So I got rid of it and I was super bummed I canceled tennis, but that's okay. I played probably the next day. So now, subscapularis. This is that rotator cuff muscle that sits on the front of the shoulder blade. It's that armpit muscle, okay? This one can refer pain to the back of the shoulder, but then also to the wrist. So again, it's like, I've got this pain in my shoulder and my wrist. Could it be coming from your neck? Yes. Okay. But could it be coming from your subscapularis? Yes. And this is where we do differential diagnosis in the evaluation to determine what exactly is going on. Teres minor, another rotator cuff muscle, commonly refers pain to the back of the arm. So you're like, it's my triceps, it's my triceps. Really, it might not be. It might be coming from your teres minor. All right, so moving on past that, I've mentioned the postural influence on shoulder pain, okay? This picture really helps to depict what happens when you go into that forward head posture. Look at all the strain that's happening to the muscles on the back of the neck, okay? And then we're shortening all those muscles that are on the front of the neck and the front of the chest, okay? So when you are in these postures for prolonged periods of time, what it does is it creates these muscle imbalances. So we get muscles on the front that shorten and muscles on the back that lengthen. And those lengthened muscles, okay, commonly can start developing trigger points, which can create headaches and neck pain, shoulder dysfunction, and the muscles on the front, as they get tight, they can also create pain, but it just starts making it hard for you to get out of that posture. As we know, things that contribute, okay, prolonged sitting at a computer, texting on a phone or tablet all the time, and if you drive for long periods of time. That doesn't mean that you cannot sit for prolonged periods of time. It just means that you have to be aware of the posture that you're in. So for example, when I have to do work for a period of time, okay, I'm going to sit for a little while, okay, and then I've got a desk where I can raise it up and then I can stand for a while. So now I'm going to get that position change, okay, and I'm also going to make sure that when I'm sitting, that I'm sitting up on my sit bones and not back on my tailbone. Because the minute that I roll, okay, my weight back to my tailbone, everything's going to fall into this posture. So I'm kind of leaning into my chair. I'm like maybe leaning on an armrest, doing everything, talking on the phone, okay? But if I sit with an active posture, okay, I get my weight on both of my sit bones, now it's going to help get everything further back, okay? So I want that to happen because if I can get my shoulders back and my head back, I'm going to take that tension and the strain off of the musculature that's holding my body upright against gravity. All right, driving. This is a really common one. I'm just as bad as anybody else. Like all of a sudden, right? So you're driving along and then you're just like, that head is just going more and more forward. I'm probably going out of the screen at this point. And I have to like remind myself, try and get the back of your head to touch the back of your seat, okay? So really try and stay up nice and tall. I don't know where I think I'm going, but I'm going somewhere, okay? And I have to cue myself just like everybody else. So we really want to avoid leaning on armrests and just getting up onto those sit bones, and it's going to really help to take that strain out of that posture, okay? Texting, yes, I mean, do voice to text or just bring it up, right? Just bring your phone up and text that way. If it's really fast, you can look down, but I mean, just don't be on your phone like forever doing this. And then all of a sudden you're like, I don't know why my neck hurts and why my posture is so bad. I mean, it's not any prolonged posture that's not good is going to result in some form of dysfunction. All right, I had talked a little bit about the ergonomic work setup with maybe using a desk that goes up and down. So you don't have to stand all day. You don't have to sit all day, okay? If there's a desk that can go up and down, that's really a nice option because what I'm doing is I'm taking the strain off of my spine and sitting, okay, with my hip in that flexed 90-90 position. And now I'm putting my hip into an extended position, okay? It's going to just change how I'm loading onto the tissues around my hips, around my spine, around my shoulder, and around my neck. It's just a really good habit to get into and good for not only shoulder health, but also for spine health itself, okay? And there's all sorts of like things that you can print to like look at to help set this up, like distance of the screen to the face, like the bend in the elbow, the bend in the hip and the knee. Like you don't ever want to feel like you're having to strain or reach. You should be in your desk setup where you can easily reach everything while maintaining a neutral posture. It should feel easy to set that up. The minute that your keyboard is too far away, okay, or the screen is too far down, things like that, then you're going to start setting up with these poor postural habits. And then once it's a habit, it's a little bit harder to break. So just try and like not have a bad habit. If you do, then break it. All right, now, what can I do if I have pain? Okay, what are my options? Well, I can ignore it, right? So I can say, I'm gonna act like this isn't an issue, and it might be my left arm, and I'm right hand dominant, and so I'm just gonna like use my right arm. I just won't use my left arm, and then it's like it was never there. Okay, well, that's an option, okay? However, if you ignore your pain, okay, the range of motion that you currently have will most likely start to further and further diminish. And then the things that you were able to do, okay, start to get harder and harder to do, okay? So what we don't want to do is just ignore it, because typically things will progressively get worse. The worse things get, the longer and more expensive it is to treat it, okay? The faster that we are able to address things, the better, okay? Because it's going to be the easiest. The longer that you've been in a poor posture, the longer that you've had a dysfunction, the more bad habits from the tissues around will start to develop. So we have more bad habits to break. We have more things going on that need attention. So it just makes that treatment plan longer and longer and longer, which is okay. We can treat anybody, but I just would rather you come in early rather than waiting for 6 or 8 months messing around with pain in your shoulder, okay? If you have an injury and after 2 weeks you are not 50% better, then you probably are not healing at a normal rate, okay? So always consider that 2-week time frame. You should be feeling better in 2 weeks. Not gone, not completely asymptomatic, but better. So don't feel like you're overreacting if it's been 2.5 weeks and you're like, I'm not any better. Like, that's not an overreaction. Your body isn't doing what it's supposed to do for some reason. Then it's our job to figure that out and help you, okay? Now, what else can I do, okay? I can alter it or I can mask it. So what that means is I'm going to go in. I've done nothing to change the biomechanics of my shoulder. I haven't changed my posture. I haven't worked on my pec length. I haven't worked on some of the strength. I've done nothing to actually create a better condition for my shoulder. I'm simply going to throw in a medication and act like it's all going to be fine. So I'm going to get a cortisone injection, and then all of a sudden my shoulder is going to feel better. But so I get that cortisone injection, and it might feel better for a little bit, sometimes a couple days, sometimes a couple months. But if I never actually changed that rubbing that was happening, because I never actually worked on opening up my joint so that I can move without rubbing, then guess what? It's going to come back, and a lot of times it's going to feel worse than it did, because you've now had weeks or months of more movement with still impinging on the tissue, okay? The other thing that you can do to mask it is take pain medication. Be like, oh, I'm going to pop an ibuprofen, or I'm going to pop a Tylenol, and then I'm going to keep doing everything I want to do and not change anything. Sure, it might feel better, okay? But if you're not actually changing the mechanics, then again, once the medication wears off, you're no better than you were, okay? The same with ice or heat or TENS, okay? Now, those are all fine to take if we're doing it concurrently with changing the pain, okay? So this is where we actually want to come in, and we want to say, let's figure you out. Let's figure out what's going on. Why is this pain happening, okay? And then let's directly address everything that's happening, okay? So we can help to avoid surgery. I'm not saying always, okay? I never make a promise that like we will avoid surgery, okay? Like surgery exists for a reason. So there are times where it is necessary, but we want to not go through unnecessary surgical intervention if we can be proactive and use your normal anatomy and heal your normal anatomy without altering it, okay? We're lower cost, obviously, than doing expensive prescriptions or injections or surgical interventions, okay? And there's minimal side effects. So you're not gonna like have any sort of like crazy drug interaction by coming to physical therapy. okay? And we're going to create a specialized treatment plan for you, which means it's individualized to your body, okay? Shoulder pain is not all the same. That's the whole point of this talk. There's a lot of things that contribute. And so we need to make sure that we're addressing you as an individual and really changing the mechanics of your shoulder and helping to calm everything down and then build you back up to get back to normal mobility, okay? So what's included? What would happen if I come in? All right. So we start with an individualized movement assessment. So we're going to go through and we're going to screen the neck, we're going to screen the shoulder, we're going to screen the mid back, we're going to look at the posture. Then we're going to ask questions about sleeping and exercising and what else is going on in your life that might be contributing to an overuse or underuse or maybe you had a recent fall or car accident or some sort of an injury occurred at a period of time. So it may not have been an injury. Maybe it just kind of came on over time. And we're like asking some questions and we're like, well, so you never had this pain before? No, about 4 months ago, it really started bothering me. And then you start asking some more questions. They're like, well, yeah, like around 5 months ago, I really started on a weight loss plan and I started exercising at the gym every single day. But before that, I didn't go at all. And so it was like this all or nothing. And then I really progressed my weight routine quickly. Okay, well, maybe there's an overuse injury. Okay, so maybe let's take a look at that exercise routine that you have going on at the gym and let's make sure that it's adequate for you. Maybe you're trying to do too much. Maybe you're trying to lift a weight that you're not ready for. Who knows? Okay, every individual is different. But these are all the things that we really want to try and find out in that first session, okay? Now, what do the follow-up sessions look like? How can you help this shoulder feel better, okay? Hands-on treatments. So we're going to get into that joint. We're going to get the joints moving that are not moving well, okay? We're going to get into the soft tissue, into those trigger points, into the myofascia, into the muscles that are guarded and short, and we're going to try and get those feeling better and moving more normally, okay? We might use things like cups. We might use things like tools for scar tissue. We might just use our hands to get into the muscle. We might use our hands to get the joint moving. It all depends on you and what's going on. But all of our clinicians here at the clinic are manually trained, meaning we have extra coursework and hands-on intervention, okay? What else would we do? Well, we can't just get things moving and not actually help with that sequencing and that firing of the muscles that help to control the shoulder, right? So we talked about, we've got the rotator cuff that helps to control the humeral head. We talked about the muscles that help to control the long bone of the arm, okay, the humerus. And we talked about the muscles that help to control the scapula or the shoulder blade, okay? So when we talk about corrective exercises, we might be stretching the pecs in the front, but we might be strengthening the muscles in the back, the shoulder blade muscles. We might be strengthening the rotator cuff muscles, okay? So it's always just trying to hone in on where are your weaknesses, where are your tightnesses, and making sure that we have a corrective exercise routine created specific for you. And then we progress that along as you start feeling better, okay? So we might have it very easy in the beginning because you're so painful and so flared up. And by the end, we might have you doing some pretty crazy high level stuff. So it all just kind of depends on you. Now, other thing that's included, okay, postural assessment. So like I've been kind of stressing, what's like one of the number one things that you can do to really decrease strain on your shoulder, okay, or even prevent shoulder pain is having a good upright posture. It's just going to give you better joint space so that you don't roll down on that shoulder and create this impingement position, which could affect the biceps tendon, it could affect the rotator cuff tendon, it could affect the subacromial bursa, okay? It could affect the neck. There's so many things that could be affected just by having a bad posture. So we really want to let's look at you in sitting, let's look at you in standing, let's talk about your workstation, let's talk about your driving, and really make sure that we're coming up with a good treatment approach so that you're getting that behavioral change to make a good, sustainable, long-term improvement. All right, so let's say, like, okay, I want to change my pain. Like, I'm ready to do this. What are my options? Okay, we do know that COVID-19 is still going on, okay? And I get that some people don't feel comfortable coming in, but some people do feel comfortable coming in, okay? In the clinic, we are wearing masks every single day. We are wiping every single surface down. We are trying to do as best we can social distancing with every patient. We've got the tables spread apart. And we're trying to be as aware as we possibly can to create a safe environment where patients can come in and be treated by clinicians and not be too close to another patient, okay? And get the help that they need, okay? We are open. We've been open through this entire pandemic, and we have been treating patients safely this entire time, okay? However, if you don't feel comfortable coming in, we can schedule a telehealth visit, okay? Not all insurances will pay for the evaluation, okay? Some insurances will pay for an evaluation that's telehealth, and some will not. So, for example, Medicare will not. So, if you come in for one visit and you're just like, listen, I'll do one, I'll be in a private treatment room the whole time, and I don't want to talk to anybody outside of a therapist, that's okay. We really want to respect your wishes and your concerns, okay? And then we could do telehealth visits after that. If you're like, I'm not going to come unless it's a telehealth eval and your insurance won't cover it, then, we'll just kind of have to see. Maybe we'll wait for a little while, or maybe you just do a cash-based option. I'm not sure. That's up to you. But most of our patients at this point in time are coming into the clinic for treatment. We have very few patients that are using the telehealth route at this point. But that's your choice. And we, like I said, we 100% want to respect where you are at that with that decision. The other thing that you could do if you're like, listen, I just have like a little bit going on and I'm not quite ready to commit to like coming in and having you take the time to look at my shoulder. You can always start with like some basic education, like what we're doing today. Like say, okay, well, maybe I'm going to work on my posture. Maybe I'm going to try and change my ergonomic workstation. Maybe I'm going to think a little bit more about what I'm doing during the day and trying to avoid some overuse type situations. And then we can always email you a couple of basic exercises. I'm going to preface, this is not an individualized exercise program that is specific for your shoulder. I don't know your shoulder. I don't know who you are, okay? But these are very basic exercises. You can try them and see if it's enough to help you where you wouldn't need to come in, okay? So that is always an option, and we want people feeling better. That's all. So if it's as easy as that, then great. So you would just shoot us an email, okay? info@premierptjax.com, and then we'll go ahead and email you a couple of exercises to try. But remember, change that posture, okay? If you stretch your pecs 30 seconds twice, but then sit like this for 8 hours, it literally doesn't matter, okay? Like you have to do both. So you've really got to make sure that you've got the behavioral change component plus the exercise component, okay? So those are your options. You can come in, you can look for telehealth, or you can try a basic, just, changing up your routine a little bit and a couple basic exercises. And then hopefully, one of those will work and help you feel better. Now, at the end, I always want to leave it open for some questions. If there's anybody that has anything burning, then that's totally fine. You can write in the comments. If not, that's fine too. Shoot us an email, give us a call at the clinic. I will always say emails are way easier. We're busy in patient care all day. Emails are much easier to respond to. But if you call, we'll do our best to get you a call back. It just might not be like within 10 minutes. Okay. So I hope this was helpful. I hope that you all were able to get some information out of this that's useful. And we're going to be continuing this series. So stay tuned, and we're going to be doing a topic a week for a little while and really trying to get a little bit more information out there to the public about conservative management. All right. Thank you.